Rahim. Assalamu alaikum and a good afternoon. I'm really grateful to Dr. Banshi Sabu and the organizing team for inviting me for this talk for Diabetes India 2022. And I'll be discussing glycemic management of type 1 diabetes pregnancy. I don't have any conflict of interest in terms of content and delivery of this presentation. So my learning objectives are challenges and barriers to achieving good pregnancy outcomes in women with type 1 diabetes, importance of preconception care in women with type 1 diabetes, and glycemic control during pregnancy, intrapartum period, and postpartum period. This is from the IDF Diabetes Atlas 2021. We know that hyperglycemia in pregnancy complicates almost 16.7% of pregnancies globally, while 80% of these are due to gestational diabetes. The rest are either due to pre-existing diabetes or diabetes which is first detected during pregnancy, previously called as overdiabetes or diabetes in pregnancy. So I'll just take you through this patient whom we saw a couple of years ago. She is Mrs. A and was referred to combined maternal diabetes clinic at 9+ weeks of gestation. She is 22 years old, primigravida, and was having type 1 diabetes for last 16 years and was married 6 months ago. She had erratic and follow-ups at the endocrine clinic for last 5 years, was taking Largine 30 units at bedtime and human regular insulin 10 to 12 units before meals. Although she was adherent to diabetic diet, but was not regularly exercising, her insulin injection sites were unremarkable. And she brought with her self-monitored blood glucose values, which were done very infrequently. And those showed wide fluctuations, and there was quite significant and frequent hypoglycemias, and she was having nausea and vomiting as well. She did not have any diabetic retinopathy on retinal assessment. Her HbA1c was 8.1%, creatinine was normal, TSH was normal. The urinary albumin to creatinine ratio was a little bit up. She was not having anti-TPO antibodies, and the fetal viability scan showed a viable fetus. So we know that poor glycemic control leads to adverse fetal outcomes in the form of congenital malformations and miscarriages. And this risk increases as the HbA1c continues to go up. So something like 9.3% A1c, there would be a risk of 15% malformations or miscarriages. And this goes exponentially up as the HbA1c continues to go up. So the window of opportunity is actually very narrow in early pregnancy. Right from ovulation, if you look at 3 to 6 weeks post-ovulation, major cardiovascular and CNS defects can occur in the embryo if the embryo is exposed to poor glycemic control at this critical stage of development. And by the time the woman would know that she is pregnant, she would be at this stage, so 3 weeks post-ovulation. And you know that if someone is already entering pregnancy in poor glycemic control, it's very challenging to bring her to control very soon. So this calls upon a preconception control of HbA1c below 7% or even below 6.5% if that can be safely achieved without putting the woman at additional risk of hypoglycemias. And in addition, a good dose of folic acid supplementation at least 3 months prior to pregnancy should be advised. There are lots of challenges in the care of pre-existing type 1 diabetes in pregnancy. These women have already got a lower standardized fertility ratio, and there is a higher risk of operative delivery and maternal ICU admission. However, it is the baby who is bearing most of the brunt of this condition. So there is a greater likelihood of neonatal hypoglycemia, accounting to almost 56-fold higher, and similarly major infant morbidity and mortality, large for gestational age babies and neonatal ICU admissions, all almost 5-fold higher than background population. Coming back to the patient, she had cost constraints for doing erratic SMBGs. We had to switch her to analog insulin because she was having frequent hypoglycemias. Her carbohydrate-containing snacks were also given bolus analog insulin. And with frequent SMBG chart review and insulin dose requirements, she was able to bring her to control within 3 weeks after her presentation to the CMD clinic. The repeat ACR, albumin to creatinine ratio, was normal, and her HbA1c dropped from 8.1% to 6.7%. So there are barriers to achieving glycemic targets and optimal pregnancy outcomes. Lack of pregnancy planning is one problem that is significant in our part of the world. Her anomaly scan actually showed intraventricular septum was not clearly visualized and a possibility of single ventricle was raised. the fetal echocardiography showed a severely hypoplastic right ventricle and transposition of great vessels. And after thorough patient counseling and with a patient and her family, they opted for a termination of pregnancy, which was which took place. So preconception care is actually important in these women. So, and that should actually start right from puberty, so that these women are aware that they have to plan pregnancy according to when their doctor allows them to do so, and they should be having a good preconception counseling, should know carbohydrate counting, how to manage their diabetes. So they should be powered enough to handle their diabetes so that they're able to achieve a good glycemic control in the preconception period and during pregnancy as well. Similarly, if they are overweight or obese, they should work on towards achieving a decent weight loss near to normal weight control, so that they do not end up having complications because of obesity or overweight. If they are hypertensive, they should be on medications which are safe in pregnancy. And similarly, their thyroid status and thyroid antibody status should be known before pregnancy. And if there are any abnormalities, that should be treated and stabilized before pregnancy. Similarly, CGM or continuous glucose monitoring devices are something which are used nowadays, and wherever the patient can afford, or you can source out these devices for your patients. These are very valuable in terms of managing diabetes in the preconception period and during pregnancy, have shown outcomes which are better compared to just alone SMBGs. Similarly, if they are using insulin pump, they should be familiar with the pump settings and should be able to adjust their insulin requirements coming from increased insulin requirements of pregnancy, should be able to adjust their pump settings accordingly. The long-term microvascular complications should also be screened for, right from neuropathy assessment for nephropathy, and retinopathy. And if there is any retinal disease that is evident in the preconception period, that should be treated and stabilized well before she conceives, because you do not want such kind of retina ending up at such kind of retina, which can happen during pregnancy because of the fact that you are trying to achieve glycemic control very quickly in these women. And similarly, the hormonal changes of pregnancy aggravate the pre-existing retinal disease as well. These are the glycemic goals, and these are the goals which are almost similar to what universally different societies are recommended, something a little bit up or down these goals. This is from the South Asian Federation of Endocrine Societies recommendations. We know that such goals are easier to achieve in the gestational diabetes women or women who have pre-existing type 2 diabetes. But for type 1 diabetes, it becomes quite challenging to achieve these goals. So this is data from 108 women with type 1 diabetes, which showed that these women were at heightened risk of hypoglycemias, mild hypoglycemias occurring almost 5.5 events per patient per week in early pregnancy, which actually decreased throughout pregnancy. But there was a risk of severe hypoglycemia in these women as well. So 45% of women experienced episodes of severe hypoglycemia, which were more marked in the first and second trimester compared to the third trimester. And these hypoglycemias actually led to hypoglycemia unawareness, and that can then result in severe hypoglycemias and led to extra carbohydrate intake and weight gain as well. So this is actually like walking on a tightrope when you're trying to achieve a good glycemic control in a pregnant woman with type 1 diabetes. The other study that was done following this study, the second cohort was the two characteristics of the two cohorts were actually tested, and you can see that for the second cohort, the focused patient education and intervention to prevent hypoglycemia was made. And although HbA1c were comparable in both cohorts as per the pregnancy outcomes in both cohorts, the risk of severe hypoglycemia and hypoglycemia, impaired awareness of hypoglycemia were far less compared to the first cohort. The women in the second cohort used mostly multiple daily insulin. Doses were lower compared to the first cohort, and similarly, most of the women were on insulin analogs and insulin pumps. When you're using continuous glucose monitoring device for your patients, the target glucose range here is 63 to 140 milligram per DL. And this is something that you will set in their CGMs. And you want these ranges more than 70% of the times. They should be, the readings above this should be less than 25% of the times, and readings below this should be less than 4% of the times. And you do not want readings going below 54 to more than 1% of the time. It is important that we should be counseling our patients that even a 5% increase in time in range will increase the benefits for mother and her baby. So suppose she was having a time in range in 50%, and next time she visits in the clinic, she's now 55%. She has already been able to have more benefits because of the fact that her control is more better now. So this is a 28-year-old lady with type 1 diabetes for last 25 years. She received preconception counseling and came for the first antenatal visit. She was taking multiple daily insulin with Detamir and Lispro. And you can see that how CGM can demonstrate a change in glucose control when therapy changes. So you can see that in her first visit, her HbA1c is 6.8%, but her sugars are all over the place. You can see that almost 49% of the time she is within target, 48% of the time. And just because of the fact that you have put on CGM and she was able to adjust her insulin doses accordingly, her sugar control is now more smoother, and she is 77% of the time she is within targets. So this is how CGM can help, because she is able to see her readings very frequently and is able to adjust her insulin requirements accordingly and is able to modify her lifestyle as well. The insulins which are saved during pregnancy are actually for bolus control. You will need either human regular insulin or aspart or Lispro. Either of these can be used depending upon whether affordability is there or not. And similarly, for basal control for background insulin, you will need either NPH insulin or insulin Detamir, or if the patient is already on glargine, that can be continued during pregnancy as well. So you can see that in the first trimester, and this is for somebody who is entering pregnancy in a proper glycemic control. Over here, you can see that the patient is taking almost 50 units per day, and her insulin requirements are actually falling down. And this is what happens in the first trimester in a good and well-controlled women, that hypoglycemia becomes a major concern in first to early second trimester, compounded by the fact that these women have enhanced insulin sensitivity in the first trimester, and the nausea and vomiting and reduced appetite actually put the woman at risk of hypoglycemia, and that can result in hypoglycemia, unawareness or impaired awareness. So these women actually need reduction in insulin requirements, and that is something that we need to counsel them, that they have to reduce insulin doses by 10 to 30%, and they have to bolus their analog insulin at least 15 minutes prior to the meal. The fact that they are not at risk of hyperglycemia at this time, which is a critical period of organogenesis, means that the risk to the embryo in terms of embryopathy will not be there. Similarly, in the second trimester, as the pregnancy advances, hyperglycemia becomes a major concern. The fetal pancreas is producing insulin, and so any small out-of-range glucose values in the mom will affect the baby, and there will be hyperinsulinemia and problems of fetal growth and other things that can be associated with high glucose exposure to the baby. We have to check for the quality and quantity of the diet, watch for insulin to carbohydrate ratio. Usually, although basal and bolus both requirements will go up, mostly it's the prandial insulin requirements that goes dramatically up during pregnancy at this stage. And remember that if the patient is taking carbohydrate containing snacks, those should be bolused as well. And then the interval between meal and insulin should be increased by 20 to 25 minutes over here. In the second trimester, the insulin requirements will continue to go up. So she started with something like 50 units per day requirements and has gone up to almost 100 units per day. And the bolus over here is called a super bolus. So her prandial insulin requirements will go up remarkably. Carbohydrate allocation has to be taken care of, and similarly, she should be having an early dinner because of the fact that progesterones delay gastric emptying. The analog insulin should be bolused at least 30 to 45 minutes or 40 minutes before meals. And the interval between analog insulin and meal is increasing during pregnancy because of the fact that insulin absorption is a little bit delayed during pregnancy. And that is why. So remember that more vigilance is required during first and third trimester. Aspirin, low dose aspirin has a role to prevent preeclampsia, and that should be started before 16 weeks of gestation. Another important thing that we as treating physicians should be counseling our patients that we do not expect hypoglycemias or more than 15% reduction in insulin requirements during mid to late third trimester. If that is occurring, that might be the first sign of placental insufficiency and will warrant post-fetal monitoring and maybe an early delivery as well. Women with type 1 diabetes are at risk of diabetic ketoacidosis, and that can happen even with euglycemia. Almost 10 to 30% of episodes of pregnancy diabetic ketoacidosis can occur with glucose levels which are less than 250 milligram per deciliter. So early recognition to prevent maternal and fetal risk should be there. And similarly, there is a risk of fetal demise after DK, almost 15% within 1 week. So women need to be counseled on prevention. So an emphasis on sick day rules. They should be counseled that they should be testing their urinary or serum ketones if their blood glucose are continuing to stay up above 200 milligram per DL, or if they are having any early features of diabetic ketoacidosis. They should be reporting to their healthcare team earlier on and should be admitted and should be treated accordingly. Intrapartum care, so during labor, you want them to be in a good glycemic control again. The target value during labor is 70 to 126 milligram per DL. And this is needed because this has a direct link with the neonatal hypoglycemia. If the levels are keeping above these values during labor, the risk of neonatal hypoglycemia would be higher. Since glucose infusions would be needed during labor to meet the energy demands of labor, you will need a separate insulin infusion for these women to keep the glucose control within target ranges. Regarding the postpartum care, immediately after birth, the insulin requirements fall rapidly. One needs to discontinue insulin and glucose infusion immediately after birth, keep on testing their blood glucose hourly. And as soon as the blood glucose goes something above 140 to 180 milligram per DL, subcutaneous insulin should be started. To begin with, it should be something like half the pre-pregnancy dose or maybe 70% the pre-pregnancy dose, and then that dose should be titrated based upon the blood glucose values. During breastfeeding, again, insulin requirements are lower compared to the non-pregnant state. Something like 70 or maybe 50% of dose might be required, but that can be varying from patient to patient and should be individualized based upon their glucose levels that you are having. Similarly, these women with type 1 diabetes are at risk of postpartum thyroiditis. So their TSH should be monitored 6 to 12 weeks postpartum and should be managed accordingly. Contraceptive advice is something that should be given to these women because you do not want them to land up in another pregnancy very soon. And that again, with a poor glycemic control, that should not be happening. So these are my take-home messages. In women with type 1 diabetes, healthy pregnancies can be achieved with right team management, team approach, and medical expertise. Starting at puberty, young women with type 1 diabetes should be counseled on preconception planning. For women planning pregnancy, diabetes care providers should explain the risk of hyperglycemia to mother and the fetus, along with the importance of careful diabetes management throughout periconception period, pregnancy, continuing through labor and delivery and postpartum period as well. Multidisciplinary care to achieve near normal glycemic targets during pregnancy is recommended. So I would like to conclude my presentation by this quotation that to the world you may be just one person, but to one person you may be the world. So you may be that one person who can help her have her bundle of joy in her arms. So I'm really grateful to your patient listening and will be happy to answer any questions at the end of this session. Thank you very much.